A very good afternoon. I'm Aisha and I will be your host for today's webinar. Kindly note that this webinar will be recorded. It is my pleasure to welcome you to our monthly ACTRIS Cell Therapy Lecture Series. Today's lecture by our distinguished speaker, Associate Prof. Goh B. Team, focuses on bone regeneration for oral and maxillofacial applications. Clinical Associate Prof. Goh B. Team is a head and senior consultant in the Department of Oral and Maxillofacial Surgery and Deputy Chief Executive Officer of Research and Education at the National Dental Centre of Singapore. She is also the Vice Chair, Research in the SingHealth Duke NUS Oral Health Academic Clinical Program and Founding Director of the National Dental Research Institute, Singapore. Associate Prof. Goh obtained her Bachelor of Dental Surgery from NUS in 1993. She then went on to specialize in the field of OMS, obtaining her dental fellowship with the Edinburgh Royal College of Surgeons in 1996 and Master of Dental Surgery from NUS in 1997. She obtained a PhD in 2009 from Radboud University, Nijmegen in the Netherlands for her novel research work. Her partnership with a local SME, Osteopore International, has resulted in successful clinical translation and commercialization for dental bone regeneration. She received the Osteopore Innovation Award for her work in clinical tissue engineering, the SingHealth GCEO Outstanding Clinician Researcher Award, and Duke NUS Master Academic Clinician for her academic achievements, and the National Day Awards Public Administrative Bronze Medal for her contributions to public health care. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the Q&A window. Prof. Goh will address these questions after her presentation. And now, without further ado, let's welcome our distinguished speaker. Prof. Goh, please.
Okay. Thank you very much for the kind introduction. And I would like to thank the organizers for inviting me to share at this webinar. And also thanks to all of you for spending your lunch hour with me. Okay, so today I'm going to give a broad overview of some of the technologies which our lab has been developing or developed, okay, specifically with oral and maxillofacial applications in mind because of my specialty, but many of these technologies can be applied to bone regeneration in general in any part of the body. Okay, so in my field of work, these are some of the examples of our clinical need for bony reconstruction. So as you can see here, we have a ridge augmentation. So this is becoming increasingly popular as people become more aware of dental implants being a modality for tooth replacement. Okay, so ridge augmentation is required because after tooth extraction over a period of time, the ridge, the alveolar ridge or the tooth-bearing bone, okay, will undergo resorption. And because of that, there will be insufficient bone to support a dental implant. So, and that's when we need to build up the bone, okay, to enable us to put in the dental implant at a later date. And then we have mandibular reconstruction. And usually this is needed due to mandibular resection for various reasons, such as tumor in the jaw, all right? And then this is another example. We have a cleft reconstruction. So many of you may be aware that of a cleft lip and palate, but actually there is also a cleft in the tooth-bearing bone in the maxilla, okay, apart from a cleft in the lip and the palate. So we also need to reconstruct this defect in the alveolus, okay, to enable either tooth movement across the gap or for replacement with a tooth dental implant. So the current gold standard is the use of autologous bone, and we may harvest this from various different sources, such as from the mandible, all right, as you can see here, or from, say, like the iliac crest, as you can see over here. We will harvest the bone, and in this case, as is shown here, is actually a non-vascularized bone. We will actually crush the bone into small particulates to be inserted into the defect, okay? Or we may look at a vascularized bone, an example being the fibular free flap, which is very commonly used to reconstruct the mandible after resection, all right? So for this bone, because it is harvested in the leg, so it is a straight long bone, so we will need to actually make cuts in the bone and then shape it and then plate it to the remaining mandibular bone stumps, and then do a microvascular anastomosis. And usually these are very long surgeries, okay? And surgeons have to work throughout the day or even night, okay, to get this job done. And because all these various techniques will require harvesting from another site, okay, these are associated with various donor site morbidities, okay, such as pain, swelling, and difficulty walking and long rehabilitation periods. All right, and when everything has healed, all right, you'll be surprised that many of the patients are very concerned about the scar. Okay, so one of my previous postdoc did a qualitative research, and she interviewed patients from our center. And in fact, the female patients will say now they don't wear skirts anymore. Okay, so long after they have recovered from the surgery, they are still scarred by the event. All right, so of course, tissue engineering holds promise to address all these problems and post-op complications by being able to restore damaged or lost tissue. And to do this, all right, we need to combine various important components of tissue engineering, such as the scaffold, cells, and growth factors. So we're all very familiar with these. But what we often forget is that it is very critical also to have a good vascularity to our tissue engineered construct, okay, to keep the cells viable. So we have heard of many successes of tissue engineering in the laboratory, okay? There's no lack of articles in the journals and all that. But relatively few success stories of clinical translation, and even fewer of commercialization of these technologies. Okay, so our lab has been particularly looking into technologies and techniques to enable us to accelerate okay, clinical translation and eventual commercialization. By adopting, making the technique as simple as possible, okay, and minimally invasive and relatively inexpensive. Okay, so for this, we would mean like avoiding the need to expand cells for a long time, you know, in a GMP facility. All right, and if possible, also to avoid, you know, encountering major regulatory hurdles by, you know, using xeno-free technologies and biomaterial modifications of existing biomaterials. Okay, so I will run through each of these, all right, highlighting some of the work that we have done in each of these areas. So first I'll touch on scaffolds. All right, so a lot of times as clinicians, we will encounter such patients who come to our clinic. They would have extracted their teeth a while ago, maybe years, months, okay? And as I mentioned earlier, following a tooth extraction, the alveolus generally undergoes physiologic resorption because of disuse atrophy. And over time, there may be so much loss of bone that there is insufficient bone when the patient now comes to say that I want dental implants. Okay, they may have been wearing a removable denture for many years, but because of the increasing awareness about dental implants and growing affluence in our society, and people want dental implants, they may you know, decide to convert their removable denture to dental implants, but by then there may be insufficient bone in the alveolus. Okay, and what we do conventionally, as you can see over here, is we will need to graft this area. And oftentimes we will then harvest this bone from another part of the body, such as the mandible. Okay, and then we graft it to this area and fix the graft with these mini screws, and then wait for about 6 to 9 months, and then go in again to put in the dental implants. But as you can see in these slides, okay, it is a fairly traumatic. I mean, I apologize for those of you who are not used to looking at bloody slides, but it is a relatively traumatic surgery, and especially patients who are coming in for dental treatment, they may not be so prepared for invasive procedures. Okay, so to prevent this from happening, all right, so this is somewhat of a preemptive kind of a treatment or management. It has been well described in the literature, this technique we use called ridge preservation, okay, whereby at the point of extraction, to reduce, all right, the resorption, we will pack in the sockets some bone substitutes, and this may be from animal source or cadaveric source, okay? And on top of it, we will place a collagen membrane or a plug, and then stitch up, all right? And while all these various techniques have been shown to reduce resorption to varying degrees, all right, it has been found that these particles, be it of animal, like bio-os is a bovine source, or DF-DBA, which is an allograft, all right, these continue to remain as non-vital particles and may even be surrounded by connective tissue. So this then reduces the predictability when we go in 6 months later intending to put in a dental implant, but we may find that you know, the bone quality may not be good enough to ensure predictable osseointegration. And so we have worked with or partnered with Osteopore over the years to co-develop the PCL or polycaprolactone scaffold for the purposes of alveolar bridge preservation. Okay, so this is a 3D printed bioresorbable polymer scaffold. And it is printed with these fully interconnected pores. And we are able to achieve up to 70 or 80% porosity to enable good ingrowth of cells and eventually bone. And the mechanical properties of this scaffold is closely similar to bone. Okay, has been optimized to be very closely similar to bone, and therefore has very favorable biomechanical properties to enhance bone growth and remodeling. All right, and it also demonstrates slow degradation kinetics. In contrast with some of the other biomaterials such as PLGA or PLLA, which may resorb too quickly and hence defeat our original objective of maintaining the contour of the alveolar bone. Okay, so this is to show how it works. All right, so following tooth extraction, we will put this scaffold into the socket, and because it is highly porous, it allows the the diffusion of nutrients and into the through the scaffold, and then the waste material out. All right, it also promotes attachment of the cells and eventually these cells to regenerate bone. Okay, so as explained earlier, our proposed solution is following tooth extraction, we will insert the scaffold into the socket, and by virtue of its 3D structure and favorable biomechanical properties, would be able to maintain the ridge while also promoting bone healing and bone regeneration. Okay, so we did a pilot clinical trial, okay, as you can see some years back. And this is a small pilot RCT involving 13 patients, 6, I think, in the test group, which received the PCL scaffold following extraction, and 7 in the control group, which following extraction, the socket was left empty and to be occupied by a blood clot as normal clinical practice. Okay, so these are just some images to run you through. All right, so we received this from Osteopore. This scaffold is roughly in the shape of a tooth socket. So after tooth extraction, we will shape intraoperatively the scaffold, the prefabricated scaffold, to fit the socket snugly. Okay, so an important point is that that it should be well immobilized. Okay, if there's any mobility at all in the scaffold, fibrous tissue will infiltrate into the scaffold. Okay, so it is snugly fitted into the tooth socket, and then the excess is removed, and we stitch up the area. And 6 months later, we went in to put in the titanium dental implant. And one uniqueness about this model is that we have the opportunity to go in again 6 months later. As you recall, we will go in to put in this titanium after the bone has healed. Okay, we will go in 6 months later to put in this titanium dental implant. So that gives us an opportunity to actually call out some bone. all right, because we need to call out that piece of bone anyway to enable us to insert the dental implant, all right? So with this core of bone, we are able to do micro-CT histology, all right? And at the same time, we also measure the ridge height and width, etc. So from this RCT, we found that there was less vertical ridge resorption in the test group that received the PCL scaffold compared to the control group. And despite the small sample size, there was statistical significance in one of the one aspect, okay? And the micro-CT and histology mainly showed mineralized bone in both groups. Okay, so with that, the results of the pilot RCT, Osteopore registered the product, and the product has now been commercialized, all right? So we have moved on to conduct another, this is a full-scale clinical trial studying the second generation osteopore scaffold. And this is the PCL TCP. So we have added on the tricalcium phosphate. And with this, we have, with the TCP, all right, the scaffolds, bioactivity, the mechanical properties, as well as the degradation profile are all improved for our purpose. Okay, so for this trial, we are looking at recruiting 138 participants, and to date, we have recruited 80 participants, all right? And definitely, we look forward to presenting our results when they are ready. So these are some of the images of this second clinical trial, as you can see here. Also, we extract the tooth and shape the scaffold. You can see it's closely mimicking the shape of the tooth root that was extracted. It is then implanted into the socket, stitched up. This is another case where we went in 6 months later to put in the dental implant, and eventually the crown is placed on the implant. Okay, so just a short video on this osteoplug that has since been commercialized. Okay, so I must say that, you know, the regenerating bone in a tooth socket would be the simplest environment for bone regeneration, because the tooth socket is actually completely surrounded by a bony wall. Okay, so in fact, even without the scaffold, bone would grow in. So and it would heal, all right? But the main objective of the scaffold is to maintain the contour and reduce the resorption of the ridge over time. Okay, so with those results, we then wanted to push the boundary, okay, into a more challenging clinical situation. So like in such cases whereby there isn't an intact, there's lack of an intact bony wall throughout. Okay, so one or more of the walls surrounding the tooth may be damaged due to pathology such as periodontal or gum diseases. All right, so after extracting the tooth, you may see that, you know, there's a missing wall. Okay, so we wanted to test if, you know, by adapting the earlier application of the scaffold for such situations, we would, you know, still achieve similar successes. And to push the boundary even further, we actually put in, instead of waiting 6 months, we put in the dental implant, the titanium implant, at the same time. Okay, so we did this in a monkey model. And as you can see here, this is the monkey. We extracted 2 anterior teeth and then took out, okay, one wall of the sockets, and then shaped the scaffold and put it into the defect, and then place the dental implant during the same surgery through the scaffold and anchoring it at the bone right at the end over here. Okay, and then in the control group, we did the same thing, except that instead of the scaffold, we use autogenous particulate bone. And this was the result 6 months later. You can see in the test group, the contour was very well maintained, whereas in the control group, there was total collapse, okay, due to the bony resorption of the graft. But on histology, all right, what we noted was in this group, in the test group where we inserted the scaffold, in these areas, and you can see, you know, these stripes here, it's actually the remnant scaffold, okay, at the point of harvest. And over here, actually, these are the original socket walls. Okay, so you can see where the scaffold was next to the socket wall, there was bone growing into the scaffold. But on this aspect, where it was adjacent to the soft tissue flap, fibrous tissue actually infiltrated the scaffold. All right, and then in the control group, yeah, you can see there was resorption and total collapse of the labial aspect. Okay, so while the use of PCL-TCP scaffold showed better maintenance of the alveolar contour as compared to the autogenous particulate bone group at 6 months, bone regeneration was only noted in areas of the scaffold adjacent to the bony wall, whereas in those areas adjacent to soft tissue flap, fibrous tissue was noted to infiltrate the scaffold. Okay. And that leads me to the next topic, which is on guided bone regeneration. All right. So this guided bone regeneration has been described again in the literature for many years. And what it does is that it uses a barrier membrane as a mechanical barrier to block, okay, the ingrowth of fibrous tissue into a defect site, thus allowing bone to grow. Okay, because as we know, fibroblasts grow at a much higher rate than osteoblasts. So to exclude, that competition, we place a barrier membrane to allow bone to grow in this defect. All right. But many of these, or rather all of these membranes available commercially are only serve as an inert barrier without any bioactive or instructive properties. Okay, and as a result, the amount of bone that is regenerated is pretty unpredictable. And we usually use this technique only for regeneration of very small defects, okay, because of the limitations. So to address this, we are developing a membrane, okay, again using PCL. And our solution to address this problem is to incorporate an instructive property into this membrane so that on the defect facing side, it is able to instruct MSCs to migrate to this region and to differentiate into bone forming cells. Okay, and whereas on the reverse side, which is facing the gums, okay, it would selectively promote, okay, fibroblast attachment. And with that, I mean, we hypothesize that it will result in a more rapid and complete bone regeneration. And this, I developed in collaboration with a PI in our team, Prof. Heman. And with this technology, we combine 3 primitive shapes, the triangle, rectangle, and circle, using mathematical algorithm to randomly combine them to form features, and then repetitions of these features will then result in a topography. Okay, so this Olympic chip has been patented. There are actually 160 topographies on this chip that will allow high throughput screening for the most optimal topography for cell attachment, proliferation, migration, or differentiation of any given cell type. Okay, so with that, we use this, okay, to identify the most optimal topography like for bone formation. So you can see here, this is the heat map for ALP, which and the red ones are the optimal, the best topographies, okay, selected for this bone formation. Okay, this one for endothelial differentiation and for fibroblast attachment. Okay, this is to show, the migration of the cells along the topographies. And after doing this in vitro work, we then identified the best few topographies and to then investigate the efficacy in an in vivo monkey model. Okay, so in this in this model, as you can see, this is the mandible. We created critical size defects, circular defects over here in the mandible, 2 on each side. And so in each monkey, we have 4 defect sites. And one, we will cover it with a PCL film with topography, with those which we identified through our in vitro work. One without, just plain PCL without topography. And another one using the commercially available collagen membrane or BioGuide, and another one with nothing. Okay, and then after that we suture up and whatnot. Okay, then 3 months later we sacrificed the animals and harvested, okay, the sites. And this is some preliminary results, okay, not published yet, but we did micro CT, and as you can see here, these are the two test articles. They have been shown to have result in significantly more bone volume fractions compared to the negative control. Okay. So again, another video to illustrate to you what we aim to use this membrane for. Okay, so we will imprint the selected topographies on the membrane. Put this over the defect site. And these topographies will instruct, okay, the behavior of cells as intended. Then regenerate bone over time. Okay, so we will then move on to the next area, which is on cells. Okay, so to even further enhance the regenerative potential of our construct, okay, we are looking into the use of MSCs. And these are traditionally harvested from the bone marrow. But however, you know, bone marrow is relatively technically challenging to harvest and may be a painful process for patients. And it has a relatively low cell yield and therefore may need further, you know, expansion procedures that may increase the cost of the technique. So we are looking into using adipose-derived MSCs, which have been traditionally been used for, you know, more popular for plastic surgery, etc. But it has been more recently discovered that ADMSCs, you know, has the potential for bone regeneration. And the advantages of ADMSCs over the bone marrow MSCs are that we are able to achieve a higher amount of aspirate, and it is able to give a higher cell yield. It is less complicated, less painful to harvest, and you know, and it has been shown to have similar osteogenic potential as the BMMSCs. And we have been using this ADIPREP system from Terumo with a patented technology using this lipid barrier disc, which is able to isolate the concentrated adipose tissue from oil and the lipid fraction. So how we perform this technique is that first we need to do a lipoaspiration from the abdomen or hip, and then concentrate the adipose tissue using this ADIPREP system. And with this concentrated adipose tissue, also known as the stromal vascular fraction or SVF, we will then inject into our scaffold and then place it into the defect. Okay, so the main advantages of this technique is that the concentration procedure is very rapid, only 4 minutes, thus allowing us the possibility of harvesting, processing, and implantation of the ADMSCs all in a single surgery. Okay, and we have since described this this technique in a porcine model. This was recently published. And what we did in this porcine model was that we extracted the teeth and allowed 3 months of healing and bone resorption. Okay, we then went in again in the second surgery to harvest the adipose tissue. And after that, with the ACTRIS system, concentrate the ADMSCs and then load it into the scaffold and then implant the whole scaffold into the alveolar defect site. Okay, so this is showing you the procedure. This is the pig's abdomen. And then this is the concentrated graft with the ADMSCs. We then load it into the scaffold. This is without the ADMSCs. This is after loading. And then it's implanted into the pig's jawbone. The pore size of the scaffold has been optimized to 2 millimeters for best loading of the ADMSCs. Okay, and again, these are preliminary results. And as you can see here, there was, I mean, we have shown the efficacy, okay, at least with the small sample size of adding the ADMSCs to the PCL-TCP. Okay, of course, the autologous bone is still the gold standard, but we have to bear in mind that in this model, when we went in after 3 months, much of the scaffold is still around, it's not degraded yet. So some of the volume would be occupied by the scaffold, okay? So, and then to even further enhance, okay, the regenerative potential, we are looking into biological, including biological mediators. And so, you know, we have co-developed these products together with Osteopore. First, the first generation using PCL, and then next, the second generation using PCL-TCP. And then now we are looking into, I mean, both products are now commercialized. And then we are looking into now the third generation by adding on magnesium and heparan sulfate. Okay, this is in collaboration with our partners in A*STAR. And magnesium has been found to be most abundant mineral in the bone, except, I mean, besides calcium, all right? And it has been shown when you incorporate this magnesium on a scaffold surface, it increases cell adhesion and also enhances bone regeneration, okay? And this is heparan sulfate. It is a naturally occurring glycosaminoglycan, and it has been shown to promote endogenous activity of BMP2. As you all would know, BMP2 has been shown to be highly efficacious in bone regeneration, but many of the commercially available products now use exogenous BMP. Okay, so and there are concerns using these exogenous BMP because there's quite a bit of variation in the, firstly in the bone regeneration capability, and sometimes it may result in overgrowth, and there is some concern about tumor formation. Okay, so heparan sulfate aims to address this this potential complication by substituting this exogenous BMP with the naturally occurring sugar or carbohydrate, okay, which is heparan sulfate, to stimulate our endogenous BMP production. Okay, and for this project, we have been fortunately awarded the ICP, as you can see here. So the work package 1 is to develop a novel co-extrusion technique to incorporate magnesium into the scaffold. And then work package 2 is to then further coat this with heparan sulfate. And then work package 3 is to then incorporate the ADMSCs. And previously for our animal work, we have been extracting the fats from the pig's abdomen. But moving on to clinical application, we will be developing a new technique of harvesting this bone from the buccal fat pad and extracting the ADMSCs from the buccal fat pad because it is closer to the area of our work. Okay, and we think patients will be more amenable to this rather than taking fats from the abdomen or the hip. And then we will move on to preclinical studies and first-in-man studies. Okay, so this to show some of the work that has been done. This work package 1 by Simtech, optimizing the parameters for the co-extrusion. As you can see here, they have developed this core shell structure whereby the shell is PCL MG and the core is PCL TCP. Okay. So again, when the results are available, we will be happy to share them. And then last but not least, vascularity, right? So this is a very critical factor which we think is it's essential for success. And it's especially important for larger defects because for these large defects, okay, they often fail due to hypoxia at the core of the defect. And we are looking for this, we are looking to neutrophils because they are the most abundant type of white blood cells in mammals. And usually they are the first cells to respond and migrate to the site of injury. And they are able to survive under very low oxygen tension. Okay, and apart from its immune function, all right, neutrophils have been shown to have angiogenic properties also by secreting MMP9, and from there, able to stimulate the liberation of various growth factors like VEGF, FGF2, etc. And neutrophils actually have a very short lifespan, okay? And when they die, the degranulation actually releases VEGF to stimulate vessel formation. And in the clinics, we are proposing this solution, all right, eventually, to be able to obtain this neutrophil concentrate from the patient's blood, okay, and then loading this into the defect site to promote bone regeneration. And for this study, we have developed a novel triple cell co-culture model, whereby you can see here, okay, this is a dual cell co-culture model, whereby we cultured osteoblasts together with endothelial cells. And we then introduced the neutrophils through the transwell membrane. And from there, we studied the, the angiogenic and osteogenic potential of the neutrophils. Okay, and we found that angiogenic markers as well as the osteogenic markers were significantly upregulated by the introduction of neutrophils in a dose-dependent manner, as well as a time-dependent manner up to 48 hours. Okay, after that, the activity starts to drop. And you can see with the introduction of neutrophils, it resulted in an increased number of these micro vessel-like structures compared to the dual cell co-culture. And this was also shown in the Matrigel assay. And you can see formation of all these junctional areas, which are indicative of functional blood vessels. And there was also, an increase in the mineralization content with the introduction of neutrophils. So we further then investigated the efficacy in an in vivo rabbit calvarial defect model. So in this calvarial defect model in the rabbit, we created 2 circular critical size defects. And in one defect, we put, we loaded just fibrin, and the other fibrin with neutrophils, all right? And in another group of rabbits, in the defect with the neutrophils, we further then injected neutrophils 2 doses, 2 days apart. So this is the repetitive application group. And this was based on our earlier finding that after 48 hours, the neutrophil activity starts to drop. So we then injected the neutrophils every 48 hours for 3 separate applications. Okay, and these are the results, and we found significantly higher bone volume fraction in the neutrophil treated groups compared with the respective controls at 4 and 8 weeks after healing. Okay, and the repeated group had higher bone volume than the single application, although that did not reach significance. And similarly, I mean, this was also corroborated with our histomorphometry findings. Okay, so with that, our study concluded that we have provided, first-hand evidence that autologous neutrophils have a positive effect on promoting new bone formation. Okay, so with that, I would like to acknowledge our collaborators from NTU, from A*STAR, as well as my team members from NDCS and ACTRIS, okay, as well as our funding agencies, our industry partner, Osteopore International, with which I have no conflict of interest. And these are 2 of my postdocs, Dr. Tanuja and Charles, whom I'm proud to say that they have received multiple awards for their fantastic work that they have been doing. Okay, thank you very much for your kind attention, and I'll be happy to take questions.
Thank you, Prof. Goh, for a very elaborate presentation on your work. We will now proceed with the Q&A session. So we have one question from Hemant. The question goes, we'd like to thank you for a wonderful presentation. And his question is, any estimation of how many colony-forming units of MSCs that you can extract from buccal fat pads? How much yield do you need for alveolar bone regeneration?
Okay, so from the literature, the yield from the buccal fat pad has been shown to be similar to the fat extracted from the abdomen or from the hip region. Okay, but as you can see in our work package 3, we will be further doing studies to make that comparison between the buccal fat pad and the abdomen, first in the pig model, before we move on to our clinical trial. But for our applications, as far as, say, for the ridge augmentation is concerned, as you know, the defect size is very small. Okay, so we know, okay, buccal fat pad, there is a limit. We definitely cannot harvest as much fat as in the abdomen, right? So it is a small volume. But at the same time, if we are looking at just regenerating the alveolus for dental implant purposes, the amount of the ADMSCs that we need is also very small. So we think this method would be a suitable method, okay, for our application. Whereas if we are looking, say, at a bigger defect, like for mandibular reconstruction, then we may need to then extract the fats from the abdomen still, but it would be more, the patients would be more amenable to it, because after all, he or she is undergoing a major surgery and would be fully under GA.
All right, at this point of time, I don't see any further questions from the audience. So we'll wrap up our presentation. On behalf of ACTRIS, thank you very much, Prof. Goh, for the enlightening presentation. And to all our audience, thank you for attending today's lecture. Have a good afternoon, everyone. Thank you.
Thank you.